Hi, this is Brian Kim. I want to share with you case number 255 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique and continually finding ways to hone and refine your technique so that you can provide the very best for your patients. So this is a cataract, pretty dense cataract, as well as a dense corneal scar and a small fibrotic pupil. You're going to see how I use iris hooks. And then even though I have hazy view, I'm going to use Trypan blue to help me. But as far as the lens disassembly, performing mechanical fracturing, cross chop, and all these techniques helps me very safely and confidently disassemble this lens. So you can see this patient has a deep set eye, and the standard Lieberman speculum is really not good enough because it doesn't allow the lids to spread apart. So I'm switching to the narrow blade speculum. Look how much better exposure I have for the surgery. This is a corneal marker, which will help me to center and size the rhexis. And using the cotton tip to control the eye, I turn the eye down and I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. In addition to that, I'm going to make my iris hook incisions. This is the sub-incisional iris hook. I'm going to make my incision through the sclera, and I make these other incisions, 4 other incisions. I first start, again, sub-incisionally with the scleral incision, make sure I'm parallel to iris plane, and then I make 4 additional incisions. And these incisions will allow me to retract the iris in a pentagonal configuration. Now, some people like to stab in the conj all the way around, but I really don't like to do that unless I have to. And this is intracameral epinephrine, and I'm using the forceps to retract and turn the eye away from me. And I used the forceps to identify where the sclerotomy was. And then I was able to place the iris hook in. And using a two-handed technique, you just twirl the hook down and then hook the edge and then pull the stopper down. I'm going to go ahead and do this for every single side. And you can see it's a rather easy and efficient technique. Some people complain that iris hooks are just too tedious and take too much time. Just remember, with rings, you can't really control exactly how much traction that the pupil has with the device, and it's not titratable. With iris hooks, you can titrate each hook individually. This gives you excellent control, and as you can see, I'm able to place each hook really quite easily without difficulty. This 4th hook, I'm really retracting the stopper all the way back because you can see there's fibrosis on the edge of the pupil, but you can see there's nice retraction. And then this last one, of course, because the pupil is so small, I really have to retract that stopper back. And I always hold it sideways, try to find the incision. I'm just going to use forceps to try to find where the incision is. Sometimes you kind of lose track. Nope. Okay, there it is. So go ahead and slide it right in. Pull the stopper back even further. And you can see that the corneal scar is right in the area where I'm trying to retract. So it's going to be a little bit of a challenge, mainly because of that view. I'm twirling the stopper down, trying to find the edge of the pupil, and then using the left hand, I'm able to engage the edge, holding the stopper. You saw that as I pulled the retractor back, it lysed that adhesion, that posterior synechiae. This is intracameral air and Trypan blue, and you really want to get good staining in this situation. And you can see that there's some chamber collapse. That's partly probably due to some zonular laxity as well as due to the density of the cataract. And I really want to get good staining in this situation. I have very poor view due to that corneal scar. Injecting some intracameral dispersive viscoelastic. And this is a 3mm blade. I know I'm going to use a 3-piece intraocular lens, and so I go ahead with the 3mm blade, and I will be using the purple sleeve for this case. Make my incision, and then these are the microrhexis forceps. These microrhexis forceps have a sharp tip, so I'm able to puncture the center. Irrigating the surface of the eye to give me a better view. Using the dispersive viscoelastic cannula to control the eye, I puncture the center, pull down towards me, grab the right side of the tear. I'm going around circumferentially, grabbing and re-grabbing, making sure I get a nice round rhexis. And over here, I go right over the corneal scar. Obviously, it's very difficult to find the rhexis, and I have to grab and re-grab. Fortunately, I was able to find the edge of the rhexis. You can see there's some fibrotic material adherent to the anterior capsule, and I'm just trying to find the edge of the flap so I can finish off the rhexis here. Go ahead and grab that part of the rhexis, and I just pull that flap off. So fortunately for me, I didn't have a radialization despite the poor view. And this is a capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally. Obviously, you can see there's not much of a wave because of the cloudiness of the view and the density of the cataract. I'm trying to sweep on the left side and then do a little bit more hydrodissection, decompressing, and then I start to spin the lens, and the lens begins to spin here. Lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. Even though I have that large scar on the left side of the screen, I'm going to still go forward with standard cataract technique, and I'll be performing the terminal chop technique first. Because of the density of the lens and the potential for zonular laxity, I'm going to debulk. So the purpose is to debulk, but then also try to cut through the posterior plate, and then I'll be hooking the chopper on the contralateral lens edge, the equatorial side, and by doing it that way, I'm able to perform a terminal chop and then propagate that chop to help mitigate the chances of a posterior plate phenomenon. So I'm sculpting, but you can see I'm sculpting, but I'm not terribly deep, and so I feel pretty good about this technique. I don't have to go too deep, because if you go too deep, you might puncture the posterior capsule. I turn the lens 180 degrees around, and I start sculpting some more. Again, this is a rather dense lens, and by debulking the dense central core, this helps minimize the posterior plate phenomenon. Switching to quadrant mode, placing the chopper around the lens contra-incisionally, placing the phakic tip deep, fracturing the terminal side, and that's the terminal chop. You see, I was able to get full propagation of the crack from the contralateral side to the proximal side. I place the chopper under the right heminucleus, hooking the peripheral lens and crushing the right heminucleus in half, and then performing successive mechanical fracturing maneuvers to remove that first quadrant. Placing the chopper around that second quadrant, crushing it and bisecting it in half again, and then grabbing the lens pieces and emulsifying the lens pieces, grabbing it with some vacuum, crushing it into smaller pieces, and then emulsifying the lens pieces. And you can see that I have good corneal endothelial protection. Why? Because I have those bubbles that are coating the cornea. So you can use that as a gauge to how much corneal protection you have. So I'm trying to do the chop maneuvers within the bag. I got rid of the first heminucleus now. I'm going to try to turn the second heminucleus in front of me. sliding the chopper under the rexus edge contraincisionally, positioning the phaco tip deep, fracturing the lens completely in half. That is another cross-chop maneuver, separating and separating, placing the chopper around that third quadrant, hooking the peripheral lens with another cross-chop, again placing the phaco tip deep, and then fracturing that third quadrant. Using some vacuum to grab that piece up, and once it's up, go ahead and start crushing it with mechanical fracturing forces, with opposing forces between the chopper and the phaco tip. Try to get that lens in a position where I can grab it, and then getting around it with the chopper and cutting it in half one more time with, again, a mechanical fracturing force. Again, please pay attention. Every time I cut the lens, I'm turning off vacuum and aspiration and ultrasonic energy. I'm only chopping with infusion only. By only chopping with infusion only, I'm able to position the chopper and the phaco tip in such a way that even if I get close to the capsule, I don't have to worry about grabbing anything because I'm not utilizing any aspiration or vacuum for those maneuvers. Placing the chopper around the fourth quadrant, crushing it in half, using mechanical fracturing forces with the cross-chop maneuver, and then using some vacuum to try to grab some of those pieces, and then emulsifying those lens pieces. Once you get to the last pieces, you want to be very mindful of the posterior capsule. So I always like to place that chopper deep to act as a shield to protect the posterior capsule from the phaco tip. This is the last remnant here. This is more like just stiff epinuclear material. Go ahead and chop the epinuclear material some more, and then using primarily vacuum to remove the epinuclear piece. Again, you can see the bubbles are completely intact, coating the corneal endothelium, which again signifies that I have good endothelial protection with this technique. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INE handpiece. I start subincisionally removing the cortical material. You can see there's some thick shards of material still, and I'm using the cannula to mash it into the INA port. Peeling the cortex from anterior to posterior whenever I can. Again, there's just some random strands of cortical material. There's no major sheets. And you want to be very mindful of using high aspiration and vacuum because you don't want to cause any zonular traction by accidentally grabbing the capsule. There's a good possibility that you can do that if you're not careful. Using the BSS cannula to pulse into the subincisional area, and you can see it's starting to liberate some of that adherent cortical material in the subincisional space. Grabbing it with the IA in polish mode, and then switching it to cortex mode to remove the lens pieces. Being able to toggle between cortex and polish mode is very valuable, being able to do that with foot pedal control. Pushing cohesive viscoelastic to fill the bag, and then using the sweeper to sweep. You can see I have some sheets of cortical material in the subincisional area. Again, the sweeper is really nice. In cases when you're not able to pulse the cortical material out with the BSS flush, using the sweeper just gives you another layer of protection and ability to clean the capsular bag, in particular in the subincisional area. This is the 3-piece lens, and because this is the 3mm blade that I made my incision, I'm able to go in without widening, turn the bevel to the left, advance the lens, but before I do that, I'm pushing more viscoelastic to fill the bag. I never want the bag to be collapsed or there to be stria, because if it's collapsed and as you put the lens in, you might tear the bag. So I'm pushing more because I see some stria again, pushing more viscoelastic, making sure the leading haptic goes into the bag, pronating my hand to let the optic come out flat, and then making sure the trailing haptic comes out pointed to the right. And then using the Maltzman to dial the trailing haptic into the bag. You want to make sure you don't accidentally grab the capsule when you do this. So you want to make sure it's pushed in further, and then you dial it in. So now the lens is completely in the bag, and now it's time to take the iris hooks off. This is very easy. Using a two-handed technique, retract the stopper back, rotate the end hook up, and then pull it out. Super easy. These are single-use iris hooks, so you don't have to worry about trying to preserve the hook. You just retract the stopper, twirl the hook, and pop it out. See how quickly that happened? Not really very difficult. And again, to me, easier and safer to pull this out than pulling out a ring. So go in with irrigation off, activate irrigation, get underneath the lens, removing all the viscoelastic from within the bag. You can see there's a bunch of stuff that's in the bag there, capsule material, lens material, whatever that was. Polish underneath the rexus edge, remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is the patient with a dense scar, small fibrotic pupil, dense cataract. I was able to use iris hooks and a subincisional iris hook as well to help retract the pupil. And by pulling the stopper all the way back, you're able to even grab the pupil in that undilated state, that fibrotic small pupil state, get around the pupil edge, hook it, and then retract it. I didn't even have to lice the posterior synechiae. I was able to just use the hooks to do that for me. And I always like to place a subincisional iris hook because this prevents you from getting iris to the wound. And if you get iris to the wound, you'll get iris trauma, transillumination defects. It just looks bad and it's really not necessary. And when you damage the iris, you can get CME and recurrent inflammation. It's just not worth it. So I went ahead and placed the iris hooks, and you noticed I never put OVD first when I put iris hooks in. I put the iris hooks in before OVD because OVDs will push the lens and capsule back. And so if it's going to be pushed back, it'll be harder to hook the pupillary edge. When the eye is soft, I'm able to hook the pupillary edge much more easily with the iris hooks. So again, make your stab incisions, allow the chamber to go a little flat. Don't put viscoelastic. Go ahead and put the hooks in. And then I used the Trypan blue. By doing the Trypan blue in before the viscoelastic, again, better and more effective anterior capsule staining. And then after I placed the Trypan blue, then I put the viscoelastic in and perform the routine cataract surgery. You saw the rexus was a little bit challenging because of that corneal scar, but because of my techniques, I was able to get a nice round rexus, perform terminal chop, cross chop, debulking the central dense core and bypassing the posterior plate phenomenon, and then utilizing cross chop and mechanical fracturing forces to disassemble the lens confidently and easily. And this patient did very well. So I hope this was helpful to you, and I thank you for your attention.